Welcome back once again. We are back to finish up our cardiovascular series, finding out your true age. How do you know what your true age is? Which is you're only as old or young as your arteries. 60,000 miles of them, by the way. It's a lot of mileage there.
Tennis
What
courts.
tennis? It's like 6 tennis courts.
Yeah.
It's also bizarre. It's also the endothelial lining is the largest hormone endocrine organ in your body.
Yeah.
It makes hormones. And so people don't realize it's actually hormone producing.
Yeah.
And if you took it and peeled off all the endothelium, it'd be the size of 6 hearts. So it'd be like, yay, 6 hearts.
Yeah.
And you think about how big is your adrenal gland? It's like,
Teeny
how big are
tiny.
ovaries? Ovaries are the size of a
Yeah.
thumb.
Yeah.
How big's your thyroid? It's like a little, and so to have like an endocrine organ that's the size of 6 hearts,
6 hearts in the surface area of 6 tennis
that's
courts.
kind of
Yeah, it's
big.
crazy.
So
Yeah.
who are the specialists who specialize in that?
Yeah. Us.
Us, yeah,
Yeah.
it's vascular biology. So,
Yeah.
so we're gonna do this session is we're trying to close things up here a bit, and we're just gonna walk through risk factors and a routine evaluation. And we're gonna divide the risk factors. And these are things that now, having said that, I wrote 200 plus, but there's like 400 different risk factors
Mm-hmm.
if you kind of get into the literature. Probably 200 and change we can measure. So we're gonna divide it into traditional risk factors and some other ones people might not be aware of
Yeah.
for the purpose of just to know what you should look at. And these I try to keep it simple. These are things that you can do with a typical provider who's willing to do a deep dive with you.
Yeah. This is
This is
this is Quest and LabCorp. This is not fancy functional testing.
yeah,
You can get this at just about any
yeah,
lab in the country. It's
yeah,
just whether or not they're willing to do it and
yeah.
how if they know how to interpret it.
The biggest thing is willingness to do it and then interpretation.
Mm-hmm.
I have
And
some
then
people
treatment.
I have some people that are well, treatment, obviously you have to have all the training for that part. But some people actually will self-test and go there's online things you can actually there's bulk lab places where people can go and actually order their own labs at a
Yeah.
greatly discounted rate and get them to check. Now, obviously, you have to figure out what to do with them, but
Yeah.
there's you can do this if you either work with someone who's curious and still learning and wants to help you as best they can, or on your own, or come see a functional practitioner like us.
Yeah.
The thing about a lot of these, I'm surprised about a lot of functional people don't do a lot of this stuff,
Yeah.
which
I
is kind
know.
of to me a little like bizarro, like
Yeah.
why, but
Yeah, I don't understand it.
yeah,
But on the flip side of that, what I'm finding to be kind of cool is I'm seeing a couple, at least of our local cardiologists doing some of the advanced testing,
yes,
and hormones maybe being tested a little bit more by some of the local OBGYNs and
yes,
hormone
agree, yeah,
specialists. So it's like if you say you're functional or integrative, you should be doing these labs, period.
100%.
And if you're not, then you need to learn how to do these labs. But it's nice to see that the conventional docs are dipping their toe in it a little bit, because then there's continuity, so that when I send someone to a cardiologist for a stress echo, they are also commenting on the LDL particle number or their LP little a, and coming up with a plan with me, instead of just like, well, we don't acknowledge
Yeah,
that weird test that's so important for you.
correct. Yeah, yeah. We don't recognize that whole field of that. There's literally a textbook on vascular biology.
Yeah.
This is pretty standard stuff.
Yeah.
But the other caveat to that is in our local environment, there is a I don't want to say too much, but there are practices that are ordering this kind of test, but the treatment is a standard of care treatment. So
Yeah.
they order, NMR and LPPLA2 and the ApoA, ApoB, LPLA, and the treatment for all those is still a statin.
Statin
Or
and
now, or
metformin and
PSK9
yeah.
now,
Yeah.
or bemsepoic acid, or some of these
Yeah.
other drugs. Not Rucols, not do you have lead, not do you have infections, not
Not what's going on in your gut, not do
yeah,
you need
100%.
hormone balancing, not what are the nutraceuticals that we can
Yeah.
use.
Well, so as we go through these risk factors right here, these are things that will alter people's cholesterol markers, but more importantly than that, that will alter your risk for cardiovascular
Yeah,
disease.
that's the big one.
I ultimately don't care what the numbers are. I want to care your disease risk.
Yeah.
If your cholesterol is 200, my cholesterol runs 220. My LDL is about 100. My HDL is about 80. My HDL particle function is 45. My LDL particle is a little high though, but my HSCRP is normal. MP, all my inflammatory markers are normal. So even though the total number looks a little concerning, underneath the hood is all fine.
Yeah.
And so that's where you have to like get into some of these nuances. And so
Yeah, it's a timeline, right? So we've talked about this. I talk about, I use the Goldilocks analogy a lot, and I use timelines, and the way that I use the timeline is If you're all the way down to the left, you have no risk, you have no disease. Then you have some risk, then you have some more risk, and you have to identify what that is. Now you have some early disease or damage. Now you have more disease. Now you have dysfunction. Now you have your event. So just getting labs isn't enough. You need some anatomical data to know where that person is, to be able to put them on that point in the timeline to then say, hey, let's see if we can push you back this other way. And then the Goldilocks analogy is just basically like a lot of these things, there's a sweet spot. Too high, problem. Too low, problem. Just right, just right. Cholesterol is that as well, right? Like cholesterol being high can be a problem, doesn't mean it is. In your case, it's over 200, which is technically abnormal, but it's not a problem for you. And if you were to get on a statin and drive your cholesterol down to 120, you would probably feel like crap. And that actually paradoxically would increase your risk for other diseases, including cardiovascular. So you have to understand the person sitting across from you and understand their biology and figure it out together. And is this number that's deemed abnormal truly a risk for you? That's where the personalization comes in.
So the categories we're looking at here: traditional risk factors, hormonal imbalances, inflammation, environmental, and others.
Yeah.
Which is and this is basically
just a bucket.
This is a bucket. Yes. So traditional risk factors, everybody knows about glucose, about blood pressure, about cholesterol, sleep, obesity. But it's interesting, a traditional risk factor is also a homocysteine level.
Yeah.
Which is not routinely checked on people.
Yeah.
But yet homocysteine is a risk factor for neurovascular, cardiovascular disease. And actually, if it's too low, it can actually be a risk factor for cancer as well. If people are
hypermethylated.
Yeah. So talk about homocysteine. I don't think I need to talk about blood pressure and glucose and
sleep and obesity.
Yeah. But to briefly give us a spiel, because this is actually a traditional risk factor, not a So tell us about homocysteine.
So I think the lens through which most people might know what homocysteine is the MTHFR gene and how that affects it, how that affects methylation. Homocysteine is kind of a surrogate marker for methylation, and methylation is, to me, it's kind of akin to a light switch. The body, trillions of times a second, in every cell in the body, it's flipping this light switch, turn it on, turn it off. It's activating, deactivating genes, enzymes, pathways, affecting change in a way biologically that allows for you to function well or not well. Well, what are the functions that are being affected? Am I making antioxidants, in particular my master antioxidant, glutathione? Am I making nitric oxide to dilate blood vessels? Am I controlling inflammation? Am I making neurotransmitters to balance my mood? Am I helping with gut function and detox? So there's so many facets to what methylation is. And then it gets a little bit more esoteric when you're talking about methylation of genes and how that leads to transcription and downstream products. But the quickest way to understand this is that if your homocysteine levels are high, you're not methylating well. If they're really low, you're over-methylated. If they're in the middle, then you're good. And for me, optimization or optimal homocysteine levels are 5 to 8, 6 to 8, somewhere around there. I'll take them if they're less than 10, but I like them in that 6 to 8 sweet spot. But again, it's got to be individualized, because if I have someone who's got a homocysteine of 7 and they're super anxious, they might be over-methylated. And if we scale back, they might feel better. So it really depends on the person. But these are influenced by genetics and nutrients, in particular B vitamins and magnesium. And then there's some minerals and some other things. And the MTHFR gene codes for an enzyme that takes folate and converts it into methylfolate. And so that's a domino that falls, and there's a cofactor nutrient called vitamin B2. So B2, along with a functional enzyme, converts folate into methylfolate, which then causes the next domino to fall, which is B12 being methylated by a different enzyme called MTRR, and that cofactor is B6. So B2 and B6 adequately, taking B9 into methyl B9, which takes B12 into methyl B12, spins the wheel and takes homocysteine, reducing it to methionine. Methionine can then go down the sulfation pathway. You can make antioxidants, goes down another pathway to make neurotransmitters, goes down another pathway to make nitric oxide, and all these things just work, or they don't. In the middle of all this is cardiovascular risk. You see stroke risk, you see cardiovascular risk, you see cancer risk, you see dementia risk, you see IBS, you see miscarriages, you see clots, you see mood disorders. All these things can be problematic if you're not methylating well. So a homocysteine should be checked in every single patient. In my opinion, should be the standard of care if you're a vascular patient, for sure.
And And just I could go off what you said for a while, but to a point, you mentioned briefly, fleetingly, some mental health issues.
Yeah.
And it's funny how there's a drug called methylene, which is a prescription for 7.5, and 10 milligrams. I think there's a 15 as well of
Okay.
methylfolic acid
Methylfolate, yeah.
that's FDA approved to treat recalcitrant depression. So what does that tell you? That tells you that, pharmaceutical companies spent, who knows, millions of dollars to take this fancy methyl B vitamin and brand it to Deplin,
Definitely,
yeah,
huh?
Deplin, to turn it into a drug that now is available in your pharmacy.
Yeah.
And it's funny how in the pharmaceutical world, once you can do that, it becomes a known entity in the medical world, but it's been known in our world forever.
Yeah.
So the idea of this concept, and even kids with different pervasive development disorders, et cetera, the neurodevelopmental pediatricians are now giving them methylate B vitamin, methylfolic acid,
Yeah.
particularly autistic kids.
Leucovorin.
Leucovorin is
Yeah.
one of this is going off track here a bit, but end of last year, some things became political and talking about Tylenol and da da da. But one of the things about autism, but one of the things that was missed in the whole conversation because it came political, unfortunately, was Leucovorin for autistic kids. And when I heard that, I'm like, brilliant. Like we're actually coming out into the public sphere mentioning there is a part of autism that has a folate receptor antibody. And what happens is it's an autoimmune process. They attach it there. And now these kids are developing autism, tics, behavior issues. And literally you can bypass that with Leucovorin, just bypasses the receptor. And so what we're talking about in cardiovascular health, we're being very, very super narrow here. But the reality is these things, the whole body, it's really kind of cool to see how connected everything is.
Yeah.
So risk factors, traditional. Now let's talk about hormone imbalances. I'm so glad we removed the black box warning off of hormone replacement therapy.
Yeah. Thank you for your most recent post. I mean, like after 23 years, they finally got it right. Like,
Jeez, oh my gosh.
I love that headline, dude. That was great.
Yeah, only got like 300 clicks on that one.
Yeah.
But, yeah, but it's crazy. You can't make this stuff up.
Yeah.
Half of all in women, menopausal women, if you put them on hormone replacement therapy, you can lower the risk for cardiovascular disease 50%, more than treating blood pressure, more than treating cholesterol.
Yeah.
And you can lower the risk for dementia 35%. So all of a sudden, these hormones, estrogen, progesterone, testosterone, pregnenolone, are a big deal. Could you talk a little bit about vasomotor symptoms? Because I don't think people realize that actually vasomotor symptoms
are cardiovascular risk.
Are a risk factor in women for cardiovascular disease.
Yeah, same as ED in men, right?
No way. Dr. Jenski, there's
man.
No way.
Yeah.
Explain to me this phenomenon.
So this is what gets lost in the shuffle is when you're looking at just traditional risk factors and you're not paying attention to whole person medicine, systems biology. Vasomotor symptoms like hot flashes are essentially a risk factor for cardiovascular disease or maybe a harbinger of already present cardiovascular disease. So when a woman goes through perimenopause and she's starting to have hormone withdrawal as the ovarian production goes down, if that's not buttressed by replacement of bioidentical hormones, these symptoms that they're having that are just treated as symptoms, here's some drug, here's some herb, here's something, get a chili pad bed, turn the thermostat down, like deal with it. That's garbage. The reality is that should be taken seriously as this person has risk for cardiovascular disease if they don't have it already, because that's akin to arteriospasm. And ultimately, if that person has plaque or stenosis, that eventually can lead to an occlusion. Same thing with erectile dysfunction. Erectile dysfunction in men could be due to arterial disease already present, or is it a vascular disease in general because it's either blood flow to or venous return from engorgement in that area. So if a young man is in his 30s complaining of erectile dysfunction, you have to take that seriously and work him up for cardiovascular disease. That's probably not happening. And so they're getting Viagra or they're getting Cialis or they're maybe getting put on Clomid and having their testosterone tested or something along those lines. But these are the things that you really have to pay attention to as, in our world, not so subtle signs, but maybe in conventional medicine, subtle signs that this person already has cardiovascular disease. Not to jump to the conventional stuff, but like going back to blood pressure, when someone comes in and their blood pressure is high in the doctor's office and at home it's normal, we call that white coat hypertension. and we dismiss it. You just have white coat hypertension, or the patient says, I just have white coat hypertension. We know that that's actually a risk factor now. The same way that if your blood pressure does not dip at night, you should dip by about 10%. If your blood pressure stays the same at night as it does during the day or goes up, paradoxical dipping, that's risk for cardiovascular disease. So these are the things that are swept under the rug or not even considered. It's the same vein with hormones. I mean, anything you want to add on that?
Well, the whole thing we mentioned with nitric oxide, we use nitroglycerin to treat angina.
Yeah.
We use isosorbide dinitrate for heart failure patients.
Yeah.
Yet our body makes our own nitric oxide. When that breaks down in some way, you can have erectile dysfunction, you can have hot flashes related to these things. But the thing is, like, and I remember this popping up probably 10 years ago in some of the conventional literature, and it kind of fizzled out because these people go to a cardiologist and get a stress test, and the stress test is normal because it's small vessel disease, because it's like glycocalyx, it's endothelium.
It's endothelial dysfunction.
It's early stuff that's not going to like rear its head for 10 or 20 years.
Yeah.
And won't be picked up by an end-stage disease test, like a stress test, like a catheterization, like an echo. But
pulse wave analysis, or endopat, or arterial stiffness studies,
or even doing a 24-hour blood pressure monitor.
Yeah.
So there are other ways to, and that's where a person could hear this, be like, okay, I went to my doctor, they blew me off or did a stress test and I was negative, so I'm fine. It's like, that was an end-stage test, not a
early upstream. Yeah.
So the other thing to think about with hormonal imbalances, PCOS, polycystic ovarian syndrome, is a risk marker for future cardiovascular disease.
Yeah.
And if you had PCOS when you're 18 or 16 or whatever, and when you're metformin and had a couple babies and moved on with your life, that's still a risk factor. Sexual dysfunction, which is getting more and more common.
Mm-hmm.
And so it's interesting how closely related hormones in order for your sexual organs to work, they're very nuanced organs, more so women than men. But if they get dysfunctional, there's a lot of downstream stuff related to that. And cardiovascular disease is one. So it's something that, isn't on the radar for us, but it's a hormonal, non-conventional thing people need to be aware of. Inflammation. So, the three finite responses: endothelial dysfunction, so it's dysfunction of that lining, immune dysregulation, inflammation. So autoantibodies, chronic stress is actually can lead to inflammation, which is high cortisol. If you have high stress, you get leaky gut.
Low DHEA. This goes back to the pregnenolone that you talked about.
Memory hormone, DHEA. It's really interesting. I'm not sure if they're still doing this study, but I read about this 5 or 6 years ago about a study to treat lupus going on at Johns Hopkins, and they're using 200 milligrams of DHEA as the drug to treat lupus.
Awesome.
When I'm like, autoimmune disease, immune dysregulation.
Yeah.
And they weren't checking people's levels; they're just giving them.
Yeah.
But the point is, in the research world, we know these things exist.
Yeah.
We have studies that look at this stuff. But part of translational medicine is taking that and then how do I apply that to the male, female person in front of me to minimize the risk.
But like the autoimmune one, like if you have rheumatoid arthritis, you have increased cardiovascular risk. If you have
0.5x.
Yeah. If you have inflammatory bowel disease, you have increased cardiovascular risk.
Yeah.
This is well documented.
Yeah. Rheumatoid arthritis is a coronary risk equivalent, meaning it's the same risk as being diabetic or having had a first heart attack for having a second.
Yeah.
The thing I didn't realize was lupus, that's like a 2 to 2.5x. So that's even a higher risk than having rheumatoid arthritis. And so all of a sudden, and you can screen for this, the whole field of predictive autoimmunity, which we put in all of our standard panels have, thyroid antibodies, rheumatoid antibodies, celiac antibodies, ANA, then SUD-rate, HSCRP, looking for these things. And if someone has a positive antibody, like a thyroid antibody, they have something like a 50 or 60% chance of developing Hashimoto's in 8 to 10 years, an 80% chance of getting lupus in 20 years.
Yeah.
But these are also markers for inflammation, for cardiovascular risk.
Yeah. And then what about antiphospholipid syndrome, anticardiolipin, seeing these things, and we see these, this is stepping into the next one, but like the toxin-induced antiphospholipid syndrome that we see a lot in SIRS patients. I mean, I see cardiolipin and we see clotting issues and like.
Okay, I want you to take a deep dive there. So what Dr. Jenski is talking about is when your cell membranes get exposed to toxins, they'll actually flip inside out.
Yeah.
And expose this thing called a cardiolipin. And if it gets exposed to your immune system, you can then develop anticardiolipin, antiphospholipid antibody syndrome. We know it's a risk for strokes in women. We know it's a risk for infertility, for miscarriages.
Yeah.
but it's toxin induced. So it's this very well known phenomena related primarily to environmental chemicals, which in the lipid medicine world, we can treat with all some cool stuff.
Yeah.
No time for that here.
Yeah.
But talk about that's a bridge between environmental factors, which is the next risk factor thing, with chemicals inducing autoimmunity, inflammation inducing heart disease.
Yeah.
Take us down that little pathway.
They're tied. I mean, it's in our world, the typical patient that I see that in is a biotoxin patient. So chronic inflammatory response syndrome. So it's a toxin-induced chronic inflammatory response. It's also an immune dysregulatory response. It's also an oxidative stress-induced response. It's also mitochondrial dysfunction. So just biotoxins alone kind of scratch all three itches that lead to endothelial dysfunction, to be completely frank. And in this case, if someone has anti-cardiolipin antibodies and they meet criteria for antiphospholipid syndrome, they tend to get put on blood thinners, right? And it's to prevent or treat the presence of a blood clot. They may have had miscarriages, but they might also have PEs, pulmonary emboli, or DVTs. And so they're either walking around on a baby aspirin or they're walking around on Lovenox or some other fancier drug. The reality is that toxins affect the cell membrane, affect the mitochondrial membrane, cause an immune response that leads to an inflammatory response that leads to vascular disease that leads to a potential future event. And as you treat that patient and work backwards, you're taking that risk and making it go the other way. Ultimately, by treating their biotoxin illness, you can actually put that autoimmunity into remission.
And the thing about that made this common knowledge this should sound familiar to the average person listening to this because of COVID.
Mm-hmm.
Because during COVID, because of endothelial dysfunction induced by the spike protein, we saw people having the shortness of breath phenomenon. I'm short of breath 4 to 6 weeks after having COVID. And I was short of breath for about a month after COVID. My D-dimer was up. It's about 0.7. I was getting microclots in my lungs. And we realized that in the COVID world, but the thing is that happens in the regular world as well.
Yeah.
And a perfect example of that is this antiphospholipid antibody syndrome, the SIRS phenomenon.
Yeah, I mean, COVID causes an endotheliitis, causes your blood vessels to be inflamed and damaged and leaky. And D-dimer being elevated typically means you got to rule out a PE, a pulmonary emboli, and you get a CTA, and it's negative, but you're still short of breath. But what if it is and it's negative, and then like, okay, you're good, but you're not good, right? Yeah. So you then got to dive deeper. Does that person need to be on some natural fibrinolytics, especially if their fibrinogen is elevated? Do they need some nattokinase or lumbrokinase? Do you start to add some proteolytic enzymes like bromelain? Like, do you boost their mitochondria? There's ways to get this better. You just have to dive deeper. But like the other environmental stuff, like extreme weather, you'd put fires or PTSD and some other toxins. I know last time you kind of touched on metals a bit. Dive into some of the environmental stuff.
Well, this is one of the things that became super obvious to me during COVID. I was actually traveling it was family vacation to the Cape Charles, my family, and actually ran into a teacher from Arizona, and talking about like, hey, why are you out here, by the way? He's like, oh well, COVID, and by the way, the fires are going on right now. And I'm like, and it's 2021. I'd never heard of that before. I'm like, fires. He started explaining to me, oh yeah, the fires in California, and then all comes down to Arizona and you can't see anything. And I was like, at that point in time, COVID was blowing up in Arizona, and the light bulb went off. Oh, we have NHANES data on smog and microparticles, PM 2.5, and strokes and dementia.
Mm-hmm.
The environment can do the exact same thing, and fires is a big one. On the East Coast, we don't really experience that a whole lot. We did a couple of years ago with Canadian fires. On the West Coast, they have a fire season.
Yeah.
LA has a fire season where literally people, and I'm getting patients from California now coming to see me here, and it's like, and you have to start, or have moved here, and you're like, okay, where'd you live? LA, where'd you live? Mexico City is another great example of a place that's horrible air quality. So all of a sudden, environmental thing, not just fires, but what's going on right?
Yes.
Well, right now, I'm not sure when this will be going out because we record a lot of these in advance, but we now know the Potomac River is horribly polluted right now, probably the biggest pollution event in our lifetimes. And what's that going to do to the people who live around the river, but also that feeds into the Chesapeake Bay, which is the biggest bay in the world, and it's where a lot of seafood comes from. Like all of a sudden, the environment becomes a big issue. Living on a farm, having, like I'll call it a gentleman's farm. We kind of, have cows and chickens for fun, not for a living, but you become aware of the environment. You learn like when it's frosting, you learn like that part of the yard's lower, it's like wetter, moisture, that part. You see like that part grows this part doesn't grow that. And so I actually got really good at predicting people coming to me for respiratory tract infections based on the environment. it's a big deal. Where you live, the environment, and fires are something. When I was in the military, I actually was stationed at Travis Air Force Base, which, it's kind of desertish. And I had a horrible reaction there. Well, there's this unique mold spore thing there that I had a horrible reaction to. This was 2021, May 2022. I'm sorry, 2002. And all of a sudden, like seeing patients around the country, you get really, your spidey sense you talk about goes up to learn which areas in the country have different issues. If you're from Long Island, you have an increased risk for cancer. If you're from the Annapolis, Maryland area, lots of pollutants. And all of a sudden, not just fires, but the environment plays into this risk.
Yeah.
And so that's part of I love, like, I've actually had to become we've had to become experts in environmental medicine.
Yeah.
Because all of a sudden now, not just fires, not just pollution, but just, in Richmond, Central Virginia, we talk about this a lot. There's a lot of endotoxins in the air because we live in a swamp.
Yeah.
And so we tend to see more CIRS, chronic inflammatory response syndrome. We also see more pandas and pans. We also see more autism because of environmental factors. And so when someone has a concern for cardiovascular issue, you have to have your radar up for, oh, my granddad had heart disease, and my dad had heart disease, and my uncles and aunts. And where'd y'all grow up?
Yeah.
What'd your dad do?
Yeah.
What'd your mom do? What'd your granddad do? He was, from the Appalachia, Virginia, and he was a coal miner and smoked. And well, okay, and your dad smoked, and you grew up in a smoking household. The person's 50, and like, oh, I don't smoke. Did you grow up? I ask this question all the time. Did you grow up in a smoking household? Yes. Okay, you smoked for 18 years.
Yeah. Yeah.
And like, people are like, what? Like, your dad smoked, right? Well, your mom, when you were inside your mom, when you were like, went from 1 cell to 2 cells to however many trillion cells, you were being exposed to smoke.
Yeah.
You came out and you're exposed to smoke for the next 18 years. It's like that affects inflammation. And so I love the environmental piece because I geek out about that way more than the genetics things. I feel like the genetics was overblown.
Yeah.
And the environmental is something we really, 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 really do not focus on enough in general. Even in the functional medicine world, we're supposed to be experts, and we get our lectures on and people forget that it's a big deal.
Yeah, and there's the paucity of quality testing too. It's almost kind of swept under the rug. You have to really seek out, you can get heavy metals testing, which you have to really seek out other environmental toxin testing. I mean, we see a lot of CIRS patients, but there's only a couple hundred of us trained in the country, CIRS certified, and it's one of these.
Hundred.
Yeah, a couple hundred. Yeah.
Yeah, it's two of that couple hundred are sitting here right now.
Yeah, it's a lot. It's a lot. But then others, obstructive sleep apnea. I mean, that's
okay. Well, we're transition. Well, I'm sorry to interrupt you.
Yeah.
PTSD.
Yeah.
This is something, I'm not sure. I think we've had the same experience, but where patients are getting stuck in their healing process, and you work with them for 1, 2, 3 years, and finally you had a traumatic life event. Whether it's your illness or whether you grew up or something happened to you. And we now know from, MACE events, major adverse childhood events, if you had something bad happen to you when you were a kid, it increases your risk for all-cause mortality. And so with our patients, when you kind of start getting into risk factors, non-traditional, beyond hormones, behind all this cool stuff.
Yeah.
What was your childhood like?
Yeah.
What was your adulthood like? Have you had horrible relationships? And also traumatic brain injuries. You can have an environmental stressor, a lifestyle stressor, a MACE event, and it can act like a traumatic brain injury on your brain. And you can do MRIs and see these things, chemical exposure as well. But the thing as well is that concussions also, leaky brain, leaky gut, inflammation. And so all of a sudden, this PTSD that used to be like, only military recruits, and only if you're sexually abused, there's capital PTSD, and then there's in my mind, lowercase.
Yeah.
It's a big, big tent that is hugely neglected, that can lead to inflammation, that can lead to autoimmunity, that can be a part, and there's direct correlation between these adverse events and cardiovascular risk.
Yeah, for sure.
That's sorry, I ranted a little bit.
No, it's the truth. It ties in. I mean, it winds up being a root cause for some of these factors, and they're all tied together. And then there's sleep apnea, genetics, mood disorders, and then infections. I mean, the infection component, I think that's another one that kind of gets swept under the rug.
So we've just finished the same. I'm finishing it. You already finished it. I'm a little behind you. Sorry, my friend.
That's all right.
Yeah. So, but it was interesting. Autopsy, patients who died from cardiovascular events, autopsies, 80% of the autopsies had oral bacteria in the plaques.
Mm-hmm.
I read another thing looking at, this was a dementia thing with dementia, but having, it was roughly about the same statistic, about 80% of, it was as small as like 20 patients that had passed away from dementia and diagnosed Alzheimer's type. About 80% of them had spirochetes in the brain biopsies,
Yeah.
which, people think, syphilis, but spirochetes are also Lyme.
Mm-hmm.
But a lot of these oral bacteria are spirochetes as well.
Mm-hmm.
So all of a sudden, and this is something we haven't really honed in on, oral health.
Yeah.
We look at infections, not just, Epstein-Barr or Lyme or whatever, but
Or
having
COVID.
COVID, yeah, but
Oral.
having horrible oral dentition, there's a direct correlation with your oral health and cardiovascular disease.
Yeah.
This is a fun rabbit trail.
I mean, also the nitric oxide. I mean,
Well,
that's where the
do that for us. Do that trick for us. Do this trick.
That's where the dysbiosis comes in. I mean, like
Do the
that to me, when you say dysbiosis, I think everyone's brain goes gut. And
Gut.
okay, great, that's true. But your microbiome for your GI tract starts in your mouth. And so you have to factor in the oral microbiome. Yeah, the trick, the oral dysbiosis component, and I think the bug that you were talking about is P. gingivalis, and there's some others that are being isolated, is how your body does or does not make nitric oxide. Nitric oxide is a vasodilator. Nitric oxide is essentially something that is inherently important for your vascularity to work properly, for your blood vessels to dilate, to be able to deliver oxygen and nutrients and things to move in the right direction. We have endogenous nitric oxide that's made at the level of the endothelial lining. So the glycocalyx plays a role, the lining itself plays a role, nutrition plays a role, all these influences. And then there's exogenous nitric oxide that we can make through foods that we eat. So we eat nitrates. The oral microbiome converts them into nitrites, and then they get into the stomach where hydrochloric acid converts them into nitric oxide. And now all of a sudden, by eating dark leafy greens and beets and having the right mouth bugs, you're able to have less cardiovascular risk. The flip is also true. If you're using a nuclear bomb mouthwash every day to destroy your oral microbiome, your blood pressure goes up, your cardiovascular risk and stroke risk go up. You are now not able to convert, even if you are still eating those foods into the products that I was just mentioning and make nitric oxide. So you have to solely rely on your endogenous production, which also may not be good if you already have some vascular disease and some glycocalyx dysfunction. And now you're just a ticking time bomb. And it all goes back to proper dentition, proper cleaning, proper mouth hygiene, making sure that you're not going nuclear on your oral microbiome. All these things that we pay attention to, also ruling out things like cavitations and pockets and, things of that nature, but super duper important.
And even like one step down, taking certain medications like proton pump inhibitors.
Yeah.
It's a correlation with proton pump inhibitors and increase hypertension, cardiovascular disease, renal disease.
By inhibiting the conversion, right?
By this process. I was interviewing Dr. Chalmers, who's like one of the top, if not the top, functional dentists in our country. And she started this amazing organization and was talking about, and she said a number that just blew my mind, that the average person swallows about 5 trillion bacteria a day. And when we were talking, I was like, wait a second. So like my fancy probiotics that I spend a bunch of money on, and like, this is the most powerful blah, blah, blah. It's like 100 billion CFUs.
Yeah.
And I'm swallowing
trillions,
5 trillion a day.
Yeah.
All of a sudden, it's like, do I spend a lot of money on a fancy probiotic, or do I floss my teeth, brush them? If I've got chronic gingivitis, I get that taken care of.
Yeah.
Brush my tongue.
Yeah.
There's a certain it's like all of a sudden, like, Americans love flashy new things. We like simple fixes, like, and sometimes it's just like a clean mouth.
Yeah.
It's ridiculously powerful. And it's funny, historically, we knew back in the day, if you look at someone's mouth, you can tell how healthy they are. And we would, back in the day during slavery, et cetera. So you look at someone and look at their mouth, if they had poor dental hygiene would actually affect how much they were worth on the slave block.
Yeah.
And not to get into that stuff, but the point is we've known about this for a long time.
Yeah.
That oral health in the diabetes world, in my primary care world, I learned very quick in MCV, Medical College of Virginia. You have your diabetics come in. The people with horrible mouths had worse diabetes, more strokes, more heart attacks, all kinds of stuff. And so how many cardiovascular experts are hammering the oral environment for cardiovascular health?
Not many. And I mean, it's also the potential source of inflammation,
infections.
Right? Infections.
Yeah.
and a host of other things. I mean, you can look in someone's mouth and sometimes determine if they have gut dysbiosis. You can look in someone's mouth and determine if they have nutrient deficiencies. If someone's got a big shiny tongue, you got to be worried about B vitamin deficiencies. If someone's got aphthous ulcers, maybe some chronic viral infection. So there's all kinds of layers to this that ultimately lead to those 3 finite mechanisms. But the most important is that oral microbiome needs to be robust and diversified and appropriate, i.e. balanced with the right bugs. I mean, I like coconut oil pulling. I like doing, simple things that have been around forever that just keep your mouth the way it needs to be to get your health back.
And there's over 200 others.
Yeah.
And so we're gonna skip those because we only.
This was enough.
But the point is,
this is enough low hanging fruit for people to start plucking.
But these are all risk factors for heart disease.
Yeah.
And if you're older than your arteries are, you need to be looking at these factors. And the things we just talked about are things that people can do. Look at.
Start low and go slow. I mean, keep it simple. You talk with your doctor. I mean, we're going to talk about how we evaluate these in a minute, but talk to your doctor about some of these or do some of the work on your own. I mean, obviously everybody can improve their diet a little bit. Everybody can move a little bit more. Everybody can work on their oral hygiene a little bit better. But now know that by doing that, you're decreasing your cardiovascular risk. You're improving your vessel age and therefore your age, your longevity.
So the risk factors. So someone comes in our office, they see us, we kind of go through their history. It's a 2.5 hour process.
Yeah.
We go through all the stuff. We get this history down. We look at traditional factors. So the evaluation. So we're now evaluating someone. Do a complete history and physical. It's really interesting in the functional medicine world. We have lectures about the importance of a physical exam and how you can use that literally. And that's one of the things in my primary care world, I got pretty good at doing a physical exam and figuring out if someone has, in my world, it's supposed to be physical exam gives you 80% of your diagnoses and you fill it up with fancy labs, et cetera, but it's often overlooked more so now in the traditional world, but also in the functional world. So what are some things when you're doing a physical exam, and I'll give some mine that you look for, and we're trying to stay in the cardiovascular risk world. Okay.
Yeah.
When you're doing an exam, what are some things you look for?
Yeah. So I think for me, you are clearly a skilled clinician when it comes to physical exam findings. As someone who came from the ER where you have seconds to make decisions, you're going to pick up on obvious stuff, but we're not necessarily looking in every nook and cranny until we maybe have a minute to do so. So this is a skill set that I feel like I still will work on for the rest of my career. But some of the things that are obvious to me, I mean, we just talked about it a bit. Look in someone's mouth. Don't skip an oral exam. Look at their teeth. Look at their gingiva. Look at their tongue. Smell their breath. I mean, these are all things that are giving you tons of information. We didn't touch on this when we were talking about the oral exam and things like ulceration and how the tongue looks, et cetera. But fissuring and scalloping, coating on the tongue, metal in their mouth. These are all things that are going to be important to me. Listening to their carotid arteries. Do I hear turbulent flow that we call a bruit? Looking at their lower extremities. Do I see edema? Do I see swelling? Do I see peripheral vascular disease? Obviously a thorough heart exam. Am I hearing murmurs? Am I hearing gallops? Am I hearing a thrill? Listening to their lungs. Do they have hepatojugular venous distension? When I push on their liver, does that neck vein pop out? There's just the touch of their skin. Are they perfusing well? When I touch their arm, it's warm. When I touch their fingers, they're ice cold. Do they have Raynaud's, which is a arterial spasm? These are the things that I'm kind of paying attention to. What are some other things that you might be paying attention to?
One a known risk factor is a horizontal crease in your ear. If you have a small thing to miss.
Is that for heart failure or myopathy?
It's for cardiovascular.
Cardiovascular in general. Yeah. Okay.
When you look in the mouth, do you have, I call cricket teeth? You don't have enough space for your teeth in your mouth. Do you have these things called tori, which are these bumpy things in your mouth? Do you have a high arch palate? Those are all risk factors for sleep apnea, which, as you know, we need to worry about that. I'm doing the physical exam also. I typically, when I listen to people's heart, I feel their pulse. Then I'll feel both pulses. And you can actually get kind of good at it where you'll notice a disparity. Okay, I feel the pulse. And if you hear the heart, I hear the heart, I feel the pulse. If there's a
delay.
You want a little bit of delay, but not a lot and not instantaneous. If it's instantaneous, it's the arteries are hard, And then traditional Chinese medicine actually This
Pulse
is part,
diagnosis
yeah,
all the
yeah.
time. Yeah.
And so, and is there a difference between the left and the right pulse? If you have a coarctation, you might actually have a little bit of a pulse
Yeah.
difference. To the point of looking at your hands, looking at nails.
Or dissection, even worse.
Oh yeah. Well, hopefully I have some symptoms of having
Yeah.
dissection. Yeah.
Nails, that's a good one.
Yeah, nails, like, do you have splinting? Do you have markers of low protein,
Clubbing.
ridging, 100% clubbing? Sometimes people will get their luna, which is the white part of the nail, will get a funny discoloration to it, splinter hemorrhaging. But even like just like the capillary, I do this thing. I know people think I'm weird because they're like, why is he playing with my hands? But you're like looking at how quickly does your nail bed revascularize after
Reperfuse,
pressure.
yeah.
Which one of the fancy tests we talked about, the endopat test, right? You cut off the blood flow to the arm for 5 minutes, you let it go, and then you look at, you measure how dilated do these arteries
you're
get.
checking hyperemia, basically reperfusion of the vessels.
And so this is a poor man's, I mean, not really a poor man's, but it's like same concept, but you're
Cap
looking
refill, it's more reliable in children, but you can use it in adults as well.
Yeah. Other things, to your point, feet, people, when they get poor vascular flow to the feet start getting these funny discoloration to them. They'll actually have like almost a hewing down to their feet. And it's interesting as you
mottled.
Get modeled. And when people have, it's really interesting. It'll get mottled initially, but then it can actually get red. Because that's like this inflammatory response before you start getting like really nasty looking. But the feet are the longest arteries in your body are going to your feet. The longest nerves in your body go to your feet. So you actually will pick up things like peripheral neuropathy in people's feet before you pick it up other places. Same thing for the vascular stuff. I also will do, blood pressure, pulse. If someone's numbers are off, I'll do sitting, laying, sitting, standing, a NASA lean test, which is looking at if I lay your body down, what's your heart do? If I sit it up, and you can, if someone's blood pressure skyrockets, that can be a marker for adrenergic POTS or a sympathetic overdrive. If it bombs out, it can be more of a neuropathic POTS. And so,
or hypovolemic.
Yeah. So all of a sudden, it's like this physical exam that is throwaway now that, all these online people, and I have some colleagues in some of the groups I'm in who pay lots of money to see fancy people, and they are non-medical trained individuals that don't even do physical exams. And I'm like, and there's literally a Bates tech. You remember Bates book in medical school?
Yeah.
There's literally a textbook on physical exam.
I still have it. Yeah. I think it's in my office.
It is. Actually, it is. Yeah. It's like, that's part of our training. How can you use the physical exam to make a diagnosis? And I feel like that is a lost art.
Yeah.
And it's important. And if, anyway, we could.
Yeah. It's obviously important, especially if you are in a situation where you don't have access to testing or don't have the funds or logistics to do a bunch of fancy testing. You can gain a lot of information from an exam that allows you to make some decisions. And then you have a dialogue with your patient and you can maybe do some therapeutic interventions. Like, it's the totality of what we're talking about. It's take a history, that gives you info. Do an exam, touch your patient, that gives you info. Get objective data, that gives you more info. Collectively, that gives you all the info that you need to then intervene and then track that over time. That's how it should be.
And the entirety of that is clinical medicine.
Clinical medicine, yeah.
Yeah. So it's a combination of science, personal expertise, clinician experience, and that
intellectual curiosity.
Yeah, that's
lost.
So routine evaluations of physical exam in the labs, doing a blood count, a comprehensive metabolic panel, fasting insulin, and A1C. We've talked about these a lot.
I like also looking at leptin and adiponectin. I go upstream with my metabolic markers. So I like uric acid a lot too. Uric acid is clearly something important for cardiometabolic disease. The leptin adiponectin component is just telling me more information about maybe a downstream abnormality like an A1C. Because if I have a patient whose A1C is pre-diabetic and their fasting insulin is normal or optimal and their glucose and their adiponectin and their leptin look good as well, that A1C is not traditional insulin resistance. It might be related to chronic cortisol dysregulation or toxins or something else. But if you just get an A1C, you don't know that. And you assume it's IR and you put them on metformin or whatever you're going to do. So the more you have upstream, the better off you are. And you can kind of see those things subtly change before you see the downstream stuff. So it's reassuring for the patient. Your adiponectin is now finally above 15. Your leptin is finally going down. You are losing weight. Your A1C hasn't budged, but it's 3 to 4 months before it budges. Let's just give it some more time. Next time you look at it, it drops by 0.5 points. And then they finally understand how that's connected. But then lipids, so lipid fractionation, which is the NMR that you had talked about, like LDL particle number and all the different sizes. TMAO, talk about TMAO. What is that, and what does that even mean?
Well, TMAO is interesting because it's a byproduct of certain bacteria in your gut when you consume carnitine, or which is a protein, and it comes from red meat, egg yolks, and tends not to be as much in fish and poultry. That if you have the wrong bacteria in your gut, they'll actually make this product that actually is inflammatory, that's associated with an increased risk for cardiovascular disease. So in my mind, the TMAO being elevated, it's a direct marker. Your gut microbiome, 100% is a part of your risk for cardiovascular disease. And I have a proven data point that tells me this is so.
Yeah, the gut-heart axis, right? Like, so now we have all these axes, and this is one where, this is my favorite one when someone's like, hey doc, I want to do a caveman diet. Hey doc, I want to do like, a carnivore diet. And I'm like, okay, fine. But you have some risk. Can we check a TMAO level first? Or can we look at your gut first? Because if their TMAO level is elevated, they have dysbiosis. And by them consuming tons of red meat every day for the next 3 months, you're increasing their coronary artery disease risk. Whereas they might be doing that to cut weight. They might be doing that to shave points off their A1C. Paradoxically, they're increasing their cardiovascular risk through another mechanism. So you have to look at it through all these different lenses in order to get it right. So that's one that I think is a little bit of an unsung hero. So I'm glad that one was on this list.
Let me go back to the A1C, your little snippet you said.
Yeah.
A1C represents the area under the curve. So what do I mean by that? If you can think about, you're fasting insulin, less than 84, whatever. You have a meal, it goes up, it comes back down. Meal, it goes up, comes back down. Snack, et cetera, et cetera. So it's like roughly 3 times a day, your sugar comes up and comes back down. If you think about all the space underneath that curve, you can have a normal fasting insulin and have an elevated A1C. Why? Because your sugar, whatever you eat, will skyrocket and take a long time to come down. It might normalize in 4 hours versus an hour and a half. Your sugar should be mostly normal within an hour after eating. If it goes up but stays up, you can have someone with normal fasting insulin, but because of what they're eating and how it's interacting with their body, which could be an issue with postprandial endotoxemia, which is a fancy way of saying you release toxins in your gut from the foods you eat, or insulin resistance, or a whole host of things. And so that's where, in our world, when people like A1C, fasting insulin, like I want people to understand that to us, when we think fasting insulin, when we think adiponectin, leptin, when we think A1C, when we think a C-peptide,
1,5-AG, which is a postprandial estimation of dysglycemia. So if you're 1,5-AG, and I don't remember what AG stands for, it's a big fancy word. It is, if it's low, you're having spikes postprandially in the 200 to 300 range.
Okay, educate me. What is a 1,5-AG?
It's exactly what I just said. So basically, it's an estimation of postprandial after eating dysglycemia. So your glucose spiking after a meal, if it's persistently spiking, because this is what we're not measuring because no one's doing a 3-hour glucose tolerance test. So nowadays we do an A1C, we do an insulin, we do a fasting glucose, we do adiponectin, we do leptin. If you're doing a continuous glucose monitor, you're getting this data. If you're doing a 3-hour glucose tolerance test, you're getting this data. But if you're not, and you have someone who says, I don't feel well after I eat, or I don't feel well after I eat excess carbohydrates, but their A1C is fine, their insulin's fine, their glucose is normal, but maybe not optimal, and you get a 1,5-AG and it's low, they're having significant postprandial spikes in their glucose. And that way you can say, look, this is maybe an issue with some early metabolic dysfunction. Maybe it's due to endotoxemia and the endotoxin's getting into the portal circulation causing problems.
So is the blood test?
Blood test. Okay. Blood test that you can get through Quest.
Oh, really?
I don't do it a ton, but I've started doing it more. 1,5-AG. And it's a postprandial.
I'll have to look into that.
Postprandial dysglycemia. If it's low, you're spiking your sugar after you eat.
Interesting.
Yeah.
Okay. Look into that. So ADMA, lipoparticles.
What about salivary nitric oxide? Do you test this a lot? I don't do this a lot.
People do it at home. Well, it's different because this is, I thought when I said go take us there, Dr. Jenski, I was hoping you'd go this pathway, but you have to eat the nitrates, you have to have the saliva, you have to have the bacteria acid. But what happens is it gets in your body and then it goes in your mouth secretes it. So maybe 20, 30% of what you're eating and gets in your body actually gets secreted. So the nitric oxide in your mouth is telling you, hey, this whole process
is working.
Is working.
Yeah.
The ADMA and SDMA is actually at your cells. saying, is it working at your endothelium?
Yeah.
So this is like a more general, like it's the pathway, you're getting enough, okay, cool. But then the question is,
Got it.
what are the arterioles doing and endothelium doing?
Yeah.
And so you want both of those. And so the idea is that, and there are some of these oral test strips that actually will also test for the bacteria associated with breaking down the nitrates in that mouth. So you can actually test for that.
Are you doing these on patients that only have an elevated ADMA, or are you doing these on like, when are you typically doing these on if they have a normal ADMA and you're like, okay, let me see if this salivary pathway is working too, or is it kind of dependent on the individual?
It totally depends, because it's like, what am I looking for?
Okay.
The ADMA is more, it's easier to do.
Yeah.
Like I've not had.
Yeah, I get those all the time, but
Yeah.
I don't do a lot of salivary nitric oxide testing. I started doing more urinary pH testing for other reasons, but like salivary nitric oxide, not a ton.
It's
interesting.
The question is, at home, and I'm actually right now personally taking some oral nitrate, 52 turning 53, and
yeah,
I want to make sure things keep on working. And so I want to know, are the things I'm eating, am I getting that 20-30% secretion? And so I kind of use it to make sure I'm getting adequate dietary stuff. So that's a way I've personally been using it, to make sure, like my mouth and stuff. But as far as the vascular disease thing, that's where I'm doing the ADMSA, that testing. But are you adequately eating stuff? And people need reminders. They need to know did I get enough today? And what I actually personally figured out is that, like I can eat all the green salad I want, but I actually need, beets work great for me. Beet powder works amazing for me. For some reason, those are the only things I can consume that will actually get my salivary. And it's probably an issue of quantity, because my SDMA, those have never been high, but I've not had enough in the system again to get that 20-30% secretion. So it's kind of like it's like filling the tank up, okay, but what's going on in the arteries?
Interesting.
The thing I've not correlated is, if this is adequate, because this requires patients give me data back. Are the patients vascular, ADMSA, SDMA, are they always okay if the salivary nitric oxide levels up?
That's what I was kind of getting.
I don't know the answer to that.
Yeah, and the other thing that'd be interesting to try to figure out, although there's a bit moving parts, if the salivary nitric oxide can somehow be a surrogate or corollary marker for hypochlorhydria. Like, do I have enough stomach acid? Like, if you think someone's oral microbiome is right and that their diet is right, and there's some way to quantify that, and you suspect they might have low stomach acid, but we're not getting a Heidelberg pill challenge, and like their nitric oxide is still low, like that would be interesting, but I don't know how you would do that study.
Well, the thing is, like, if you're consuming excessive amounts of green leafies, you could overpower that.
Yeah.
I know I've got some hypochlorhydria issues.
Yeah, I know I do
and
too.
some issues, but I've been able to get my oral salivary numbers up.
Cool.
So I think this is where clinical medicine comes in.
Yeah.
No one's paying millions of dollars for that study.
Yeah.
But when you get these questions and you start doing it with patients, and you get the data point back, that's what we do.
The cool thing is that, I mean, I'm sure your patients are the same way. My patients are game for all this. They're just like, they love it. They love the data points. You know me, I test like a lunatic. So so we have tons of data. We have data for days, man. What else? Thyroid, vitamin D. Man, it's so important.
Vitamin D for cardiovascular risk needs to be over 50. For autoimmune issues, needs to be between 60 and 80. And if you have a history of breast cancer,
even higher.
Closer to 100. Yeah. And so vitamin D is super nuanced, just like an A1C is super nuanced. Being adequate at 32 is not enough.
No, I try to push everybody above 60.
Yeah. And then a routine evaluation, I wrote down like ANA, rheumatoid factors,
so autoimmune stuff,
thyroid antibodies, fibrinogen. These are just the markers for the hormones: FSH, LH, estrogen, sex hormone binding globulin, prolactin, pregnenolone, estradiol. All these things will probably be in the show notes if people want to look at that. These are I don't want to belabor time, but the cognitive labs, I think, is interesting because when we did our training, Dr. Houston's stuff was my very first. The cardiovascular module was the very first. It was just like, it took me 3 months to digest those 3 days of information. It was just.
He's the only functional clinician that I've gone up to personally after a lecture to shake his hand and say thank you.
Oh,
Like everyone else, I just like
You're like,
sat and
"Oh."
listened to their lectures
Like,
and like
okay.
took notes and was like, okay, this is cool. I'm learning a lot of new stuff.
No,
I was so in awe. It flipped everything I learned on its head that I had to go up and be like, thank you. Like my
I
eyes
had,
felt open. That's why I call
I,
him Oz.
I
He's
just
like,
had,
he pulled the curtain and was like, this is how it really
for
works.
me, I was like, I'm taking notes. I have no idea what you're talking about.
Yeah.
I had to go back and like read and read and read.
He's the goat, man.
Yeah. But anyway, so I did his thing and then did Dale Brenson's work, which he is the expert on
Dementia.
dementia. And it was really interesting because the evaluation is like 89% the exact same thing. And so the point is like, if someone's got cognitive markers like the beta amyloid is off, the beta amyloid 4240, their p-tau 217, which we can
Yeah.
now measure.
Yeah.
As of 3 months ago, we can now test these things.
Yeah.
I think the point to what people are listening to right now, literally, I've changed some of my testing in 3 months because this is now available.
Yeah.
Like, that is really cool.
Yeah, it's
that
called
these things-
AD Detect. You can get it through
Yeah.
Quest, and these are
Yeah.
included. And you can also get ApoE status on there. You can also do
Yeah.
neurofilament light chains,
Yeah.
NFL, and this gives you information because this is the kind of stuff that you're going to see abnormal years before evidence
Yes.
of cognitive decline, and you want to catch it because it might have vascular pathology behind it, or be tied to the other risk factors that lead to vascular pathology, right? Is this person's amyloid beta secondary to chronic infections, which will inevitably become vascular? Is it tied to toxins? Is it tied to heavy metals? Is it tied to chronic inflammation? Now you're getting a different target end organ data point saying there's something wrong with me. Go figure it out.
And one thing I'll tell people as well that it's interesting in the kids with these kind of tests are not determinative. They're helpful. One of the reasons why these tests are now available is because some of the treatments now, beta amyloid treatments, they require this to be positive before insurance companies will pay for stuff. So that's part of the reason why these become more commercial. The other thing to think about is that this is something I learned recently, that in the Down syndrome world, Alzheimer's is much more common. I've had one patient that had Alzheimer's when she was like 28. And there's interesting studies looking at, so they, because of their genes, they're way, way more prone to heart disease, dementia stuff. But it's interesting, in that world, you might have two brains that have the same pathology. And one Down's patient, or one child, adult, will have dementia and one won't. And this one study was looking at the difference was their diet. The diet with this increased beta amyloid laying down could make the difference between this 40-some-year-old needing to be in a memory care facility with their dementia and this one not.
I wonder, did they check ApoE status on those patients?
Because
diet would play a role there too.
100%. It was, and obviously part of Down syndrome is they have methylation issues.
Yeah.
Which is one of the reasons why diet is so ridiculously important in that population. Because if you have a methylation deficient diet, hyper-processed inflammatory diet, you're going to go around
all those processes that we talked about go sideways. And just to be clear on these labs, this is not how you diagnose dementia.
Correct.
These labs give you a likelihood score, or low, intermediate, or high likelihood of PET scan positivity. So it's just a guide. It's just a tool.
Well, actually, the way it came about was they were doing like, how can we, because previously the way was we'll do a spinal tap for a beta amyloid, which who's going to,
who's going to volunteer for that?
Yeah. Oh, come on. Yeah. Screening for dementia, spinal tap.
Come on down.
Yeah. And so they eventually got the test fine-tuned enough that they could actually do the blood levels and it would correlate with the spinal tap. And therefore, this correlates with central nervous system.
Awesome.
So it's a correlation. It's not determinative. Doesn't mean you're going to get this, but if you have it, you need, and just like the whole thing, like my point of mentioning the whole Down syndrome world, you can have the brain pathology. But what are the downstream things that are leading to that? Is your diet horrible? Are you inflamed? Do you have an ApoE4 status and some of these other genes, a 4q21 and blah, blah, blah. That makes, if you have these things, it makes the diet and lifestyle stuff even more important.
Exponentially so. And then what about functional testing?
Functional testing, I put sleep.
Sounds like we just talked about functional testing, but believe it or not, all those are regular labs through Quest and LabCorp. Like, doesn't it? Like, it seems like we were just like that's the irony of all this. Is like every clinician has the ability to order these tests. Quite literally, you don't need to have access to some functional lab.
But
so let's talk about functional lab testing.
But to keep things in perspective, we also have between the two of us, we have 6 board certifications.
Yeah.
So it's maybe not fair.
It's a lot.
It's a lot. Yeah. So that's kind of crazy when you say it like that. Anyway, functional testing. So this is actually in the functional medicine world, looking at doing advanced stool analysis, where you can actually, there's a newer test I just did myself that actually would analyze and say if I had oral bacteria in my gut associated with some of these things. Yeah. The HPA axis, we talk about trauma, we talk about high cortisol. Yeah, we talk about your brain with your thalamus, with your pituitary, hypothalamus with your pituitary, going to cortisol, going sex hormones. We can test that, do a HPA axis test.
I do that. I do a poop test and a spit kit on every new intake. You can't get through the gate without it.
Yeah. The methylation is just, could be MMA methylaminic acid, that could be genes COMT, could be gene testing.
100%, but also there's a lab that I use that does a methylation panel where you can measure SA, SAMe, serine, glycine, homocysteine, methionine, all these things. So you can see not only the genetics, but literally it'll map out your pathways.
I tend to do that on my neurodivergent kids.
I do that on somebody whose homocysteine is like 30, and then I throw the kitchen sink at it and it still doesn't come down. And I'm like, what am I missing?
Okay, fair enough. Yeah. We're going to talk about that in cases next.
Yeah, cool.
I've got one of those. Sleep apnea, I feel that every patient period should be checked for sleep apnea.
100%.
We say, this is like, falls into the medical blind spot, medical gaslighting world kind of sort of, where maybe even becoming a medical feminist. I kind of stole that from you, by the way.
Yeah, it's all right. We can share it.
We can share, yeah. But the idea is that obese males with thick necks is how their standard Aries evaluation is based on.
Yeah.
And so it's like obese males with thick necks, but can someone who's slender, who has a poorly developed mid-face, underface, who has dental crowding, has an Irish palate, can they have upper airway resistance syndrome, which is a kind of sleep apnea? Yes.
Yeah.
And that's where most of my diagnoses of sleep apnea are coming from
or
now.
hypermobile patients.
Which is a part of their thing, 100%. So all of a sudden, everybody's getting this.
Yeah, same. I think it's underdiagnosed, undertested. I'm about to get an updated test, as I was talking about with you earlier. I mean, I had moderate to severe sleep apnea when I was 230 pounds. I used CPAP, I lost the weight, and I thought I was done, and I had mild sleep apnea. So I wore an oral appliance. I've stopped using it, and I'm going to get an updated test to see where I'm at.
And then there's some of the cool things which we are hoping to add here in the future, which are the endopat and pulse wave analysis.
Yeah.
Tell us about, what is an endopat briefly?
Yeah.
That's a pretty cool test.
Yeah.
And what is a pulse wave analysis, which is another pretty cool
I mean,
test.
The shortest version is they're both kind of giving you input about the arterial stiffness, and essentially another term we use is compliance. And so basically, how compliant is the blood vessel? How able is it to expand and dilate and contract when necessary, if necessary, or is it too stiff? And as it gets stiff and calcified and plaque laden, hardened arteries is the term that people use, then you have vascular disease. And the cool thing is that this is very upstream of those the larger vessels, which means we're now detecting small vessel disease.
And the key to that is, this is where you're finding the stuff 20, 30 years before it happens.
Before, correct.
Yeah, and so you address this, fix it. And even if you have heart disease and vascular disease, if your cholesterol's fine, blood pressure's fine, and this is off, it still needs to be addressed.
Yeah, you got to be aggressive. Yeah. CACCT and CIMT we've talked about at length. CCTA is pretty great if you can get it. It's a coronary CTA or CT angiogram, and then typically it's with something called FFR, which is fractional flow reserve. And then there's an AI overlay with a specific study called the Clearly study. And the best way to explain this is that it's like an external catheterization. I mean, it's literally giving you an analysis of your blood vessels, your coronary arteries, and where you have plaque and what type of plaque it is, and an estimation of stenosis. So it's quite literally like a cath without the invasiveness of a cath. I mean, you are getting contrast, and it's an expensive test that's not covered by insurance, but it'll tell you if you have soft plaque or calcified plaque. Is it lipid rich? Is it necrotic? Where is it? How distributed is it? Is it one vessel? Is it multi-vessel? How stenotic are they? And it just becomes a nice way to kind of understand if you're in one of those blind spots where I have risk. I had a CACCT that came back with a score of 100. I got a stress test. It was normal. They told me I'm good. Just take my statin. And then you get a CCTA and you got soft plaque everywhere. Yeah. Like, that's clearly, you got to be more aggressive there.
And using things like K2, MK7, garlic, using the things that help with the glycocalyx, nitric oxide. All of a sudden, you can actually help these soft plaques improve.
Regress.
Yes.
Yeah.
So that's kind of it as far as Now, this is the reality. We do a lot more than this. We do a whole lot more than this. So I don't want people to think this is all we do, because we can't say everything I was actually looking, we're already like in an hour. I'm like, oh my gosh, I can't believe
It is a long one.
Yeah, I know. So, but the point is that the risk factors are pretty standard. There's a bunch of basic stuff you can do, and then there's really cool things you can do. But I always like to end it on, 80% of heart disease, 7% of most cancer can be prevented by diet and lifestyle alone.
Yeah.
So perfect the basics, then do all the cool stuff.
Yeah. And individualize it.
100% has to be individualized based on the person in front of you, not based on, 10,000 people in some random study that was in a different part of the country and on different ethnicity group that happened 20 years ago, right? And you're like, but
yeah.
Well, hopefully this was helpful. We're going to end up talking about some cases of real people that we've seen. That's how we're going to end this series up, hoping people can realize and give people the tools to take charge of their real age, which is the age of their arteries, and to help prevent the number one cause of death in our country, which is cardiovascular disease. So anyway, take care, everybody, and we'll talk to you soon.
Care.